with us to enlighten us on the novel therapies research for post-hemorrhagic white matter injury and hydrocephalus. Professor Praveen Ballabh. Dr. Ballabh is Professor of Pediatrics and Neuroscience and investigator for Kennedy Intellectual and Developmental Disabilities Research Center at Albert Einstein College of Medicine, Bronx, New York, USA. We all know he is a great researcher. He has done extensive research on the cellular and molecular mechanisms of brain injury produced by IVH in preterm infants. And now I'm told he focuses on developing strategies to restore the development and function of brain in survivors with IVH. For these studies, he has developed a unique model, something very unique, of glycerol-induced IVH in prematurely delivered rabbit pups. Using this model, he has already shown that COX-2 inhibition, pyroxine treatment, or degradation of hyaluronan, all these enhance the myelination and neurologic outcome in rabbit models of IVH. Just to mention the amazing work that he does, well, he has already a collection of more than 135 brains of short post-term intervals from fetus and preterm infants over the last 10 years. He has recently published on the effect of IVH on glutamatergic and neurogenesis and interneuron neurogenesis. This article, I'm sure most of us would have read in Brain last year, and then previously the similar publication came in Cerebral Cortex in 2018 as well. His marvelous team has extensive experience in performing developmental studies to assess the effect of IVH on cerebral germinal matrix, white matter, and gray matter. Friends, I shall not go on and on with his contributions to neonatal neurology and research due to lack of time. Instead, let's hear from the legend himself. But before that, I would say the greatest quality that I found in him as he is a humble human being. Despite all the research and all the laurels to his credit, he is a very humble human being and very nice gem of a person. Over to you, Professor Praveen Ballabh. Over to you, sir.
Yes. Just bear with me 1 second. Okay. Thank you so much, Manoj, for such a kind and wonderful introduction. And I'm grateful for inviting me to this forum in which I can talk to pediatricians all across the world from several subcontinents. And it's really an honor to give a talk in this forum. And thanks again to all of you who have joined to listen to this talk. So let me now share the screen and, okay. I hope you can see the slide. Now let me blow it.
Yes, sir, we can see the slide.
Yes, yes, great. Okay. So as Dr. Manoj said, that the title of my talk is Novel Therapies for Post-hemorrhagic White Matter Injury and Hydrocephalus. By post-hemorrhagic, I mean post-IVH, post-intraventricular hemorrhage. And this is a picture of Kennedy Center. My lab is on 7th floor. Can you see rabbits here? Perhaps you cannot. Okay. And these are the buildings of Albert Einstein College of Medicine. I have nothing to disclose. About 12,000 premature infants develop intraventricular hemorrhage every year in the United States of America. So which is about 20% of 32 weekers, less than 32 weeks, about 20% they get intraventricular hemorrhage. The good news, with advances in care, there's a shift in neonatal morbidities towards milder neurocognitive impairments, which means, see, the severe cerebral palsy has declined, whereas mild CP, mild cerebral palsy, has increased. So with time, we have reduced the severity of cerebral palsy by improving our neonatal care. Now, neuropathological changes in IVH. Look at this pretty picture. This is a microscopic picture of brain ventricle stained with hematoxylin eosin. Whole red thing is a blood clot. which is sitting in journal matrix. You see, this is nuclear staining. So this is journal matrix. And this is covered with a thin layer of ependyma so that blood has not leaked into the ventricle. So this is grade 1 IVH. Now this journal matrix is home to a neuronal progenitor, to glial progenitors. And if there's hemorrhage, many of these cells, they die or their growth is jeopardized. Now look at this picture. This is grade 3 IVH, and there is also infiltration in the parenchyma. So this is grade 4. So this is a picture of periventricular hemorrhagic infarction, which is seen in large intraventricular hemorrhages. And this is attributed to compression of the terminal vein, which gives rise to parenchymal necrosis. When we follow these infants, we see porencephalic cyst, cerebral palsy, and cognitive deficits. Here you see holes in the white matter. This is periventricular leukomalacia. You see this? When we say periventricular leukomalacia, we tell the families, say 60 to 90% chance of cerebral palsy. So it's a very like a diagnosis which indicates bad outcome. This is 26-weeker with blood in the ventricle. And after 4 weeks, there was hydrocephalus. So these are the neuropathological changes that we see in IVH in nutshell. Now, this slide is an overview of white matter injury. Why does a baby with IVH gets white matter injury? IVH, there's formation of a blood clot into the ventricle. Clot lysis releases hemoglobin, iron, thrombin, complement, which induces oxidative stress, inflammation, and glutamate toxicity, damaging the axons, the wiring of the brain, and oligodendrocyte progenitors, which forms insulation around these wirings, which is myelin. The net result is reduced myelination and white matter injury. In addition, there is blood-brain barrier injury, compression, mass effect. At this time, there's unfortunately, no proven therapy for white matter injury. There's no proven therapy for white matter injury. What I'm going to talk today is all experimental and perhaps in the pipeline. So strategies to reduce white matter injury. Number 1, removal of the blood product. See, ventricle has blood. Can we remove it? By surgical clot removal, by surgeons going and removing the clot, or using iron chelation, thrombin antagonist, or hemoglobin scavengers? Or can we reduce inflammation, oxidative stress, and glutamate toxicity by using, say, COX-2 inhibitor, aminocycline, TNF-alpha antagonist, chelating iron, or reducing glutamate toxicity by AMPA antagonist? In IVH, oligodendrocyte progenitors, they fail to mature. These progenitors, they are arrested in non-myelinating stage. They are there, but they cannot mature to myelinating stage. Can we promote their maturation by giving thyroxine or other ways, which we'll talk about? So let us focus on blood clot removal. He is Andrew Whitelaw. Andrew Whitelaw is Professor Emeritus at Bristol University, England, UK. So he was the PI for DRIFT clinical trial. DRIFT is acronym for drainage, irrigation, and fibrinolytic therapy. The promise behind his clinical trial was removal of blood products or removal the clot from the brain ventricle of babies with intraventricular hemorrhage would reduce incidence of PHH, which is post-hemorrhagic hydrocephalus, and will minimize neurological impairment. So this was his hypothesis. He included premature babies with intraventricular hemorrhage who were less than 28 days. So mean age was about 21 days, postnatal age 20, and ventricular index, which is how much is the dilatation of ventricle, more than 90th percentile plus 4 millimeter. So what he did, look at this picture. He called pediatric neurosurgeons and they placed catheter. This is in the entry horn on the right side and one catheter in the posterior horn. Here you see in the left side. And he infused recombinant tissue plasminogen activator in the brain ventricle and lavage the ventricle at 20 ml per kg per hour with artificial CSF. For how long? 2 to 7 days. It was very invasive. Did it bring any benefit? See, VP shunt rate was similar. So ventricular peritoneal shunt was similar. It means it did not reduce hydrocephalus. Clinical trial was unfortunately stopped because many of the babies got secondary hemorrhage. Now, when these babies, so he had a smaller number of sample size, standard care 38, and those who got drift, those who got this treatment was 39. Death rate was similar. And you look at this, severe cognitive disability, 35% in drift, 59% in standard care. And this was statistically significant. So babies who underwent drift have reduced severe cognitive disability. Based on this result, from Germany, Sulj et al., they did neuroendoscopic lavage, which means placing an endoscope in the ventricle and flushing the ventricle with ringer lactate. So he included in this study babies with head circumference more than 2 millimeter per day, or ventricular dilatation more than 90th percentile plus 4 millimeter, or entry horn width more than 90th percentile were included. So he included typically progressive severe hydrocephalus cases. And endoscope was placed and ventricle was lavaged with ringer lactate, just 2 to 3 liters. And this study reduced ventricular peritoneal shunt insertion rate. But look at the sample size, very small, 10 and 9 control. Another study, Etas et al., included 23 babies. So, and they also found reduction in shunt rate. So such a simple size is the weakness of the studies. So based on this, we can say that these studies are feasible and holds promise. We need to do a randomized clinical trial, which involves bigger sample size. Now, next I will talk about iron chelation and thrombin toxicity. Early brain injury is caused by thrombin, complement, and immunoglobulins. Later injury, when there's a lysis of RBCs, iron is released, they cause late injury. So thrombin activates protease activated receptor, PAR receptor, which activates NMDA receptor, more calcium entry in the cell, more damage. ROA signaling is affected, MAP kinase signaling is affected, NF-kappa B, inflammation, apoptosis, cell lysis. There is inflammation in the brain. If there's more inflammation of choroid plexus, more CSF is produced, contributing to hydrocephalus, causes blood-brain barrier injury and ependymal damage, blocking the aqueduct. The result is hydrocephalus and white matter injury. So antithrombin treatment has been tried in preclinical trial in animals, not in. So in mouse model, it improves myelination. So this Voraxapar is this was FDA approved for treatment of thrombotic complication of myocardial infarction, but it did not bring benefit in adult stroke patients. Another compound, dabigatran, FDA-approved anticoagulant, has reduced hydrocephalus in rat model of IVH, in rat model, but it has risk of increasing secondary hemorrhage, IVH. Disferoxamine has been tried in animals and also in a small clinical trial, but the safety and efficacy of these treatments are uncertain. Now, brain injury in IVH is caused by inflammation, oxidative stress, and glutamate toxicity. And these pathological processes are interlinked. Microglia is activated, releases cytokines, free radicals, which cause oxidative stress and inflammation. Synapse has glutamate, but released glutamate is not taken up because glial transporters are downregulated. There is glutamate toxicity. Oligodendrocyte death, maturation arrest. There is reduced myelination. So in one of our studies, which we published in 2010 in Brain, we used COX-2 inhibition, cyclooxygenase 2, which releases prostaglandin, prostanoid receptor, and TNF-alpha. To inhibit these and see that it improves the outcome. Does it improve myelination in our rabbit model? So my hypothesis was that inhibition of COX-2 receptors or prostanoid receptor, EP1 or TNF-alpha, might minimize brain damage in infants with IVH. Rabbit model is unique. You may not be knowing it. So let me tell you briefly about rabbit model. Rabbit pregnancy is 32 days. I delivered them E28 or early E29 by C-section. So they are exactly E28.5, means 3 to 4 days early before the normal delivery. And give them glycerol, not in the brain, in the peritoneal cavity. And next morning, I do ultrasound. Or if you sacrifice the animal, you'll see moderate hemorrhage, severe hemorrhage, microscopic hemorrhage. This is the ultrasound of rabbit brain. You see the echogenicity. This is IVH. No IVH. There's no echogenicity. I quantify severity of hemorrhage. When we follow these infants, see, this is a big hemorrhage in the ventricle. This is a coronal section through the brain, rabbit brain, frontal lobe. And on day 14, see, they get hydrocephalus. Very, very impressive hydrocephalus these animals get. And so, I have not succeeded in totally fixing hydrocephalus in my animal model. And 25% they get paralyzed. So this animal we created about 16, 17 years back at New York Medical College when I was there. Now I'm an EINSTEIN. So let us look at how we designed this study. We did C-section and then bring to the lab. And on day 1, at 4 hours age, give them glycerol in the peritoneal cavity. Next morning, see the hemorrhage by ultrasound. Those who have IVH, randomize them, celecoxib or ventricle, Celebrex or vehicle. What is vehicle? Celebrex we dissolve in DMSO, and DMSO is the vehicle. So vehicle is a kind of placebo. We treat every day for 7 days. Kill the animal on day 14 and look at the brain for myelination. So look at the brain. This is a myelin basic protein immunohistochemistry. You have, so this is immunohistochemistry. You can clearly see that here myelin is very dense myelin. Myelin is sparse, and comparison was significant. Then to confirm it, we performed Western blot analysis. You may not know, many of you may not know how to read Western blot. It is very simple. So you see 1, 2, 3, 4, 5 bands, non-IVH day 14. So if band is bigger, means more myelin basic protein. If band is weak, as you see in hemorrhage, means less myelin basic protein. We do densitometry to quantify. When we give celecoxib, you see that myelin basic protein was increased here, and comparison was significant. Now GFAP, when there's a hemorrhage, there's a damage to the brain, then there is more gliosis. Astrocytes, they proliferate. In layman terms, there's more scarring in the brain, more scar formation. So celecoxib treatment reduced GFAP. It reduced scarring in the brain. So celecoxib treatment might enhance myelination and reduced scarring in the brain in infants with IVH. So this has never been tried in clinical trial, but this holds promise. Now, other investigators have tried minocycline in collagenous model. So, this work is done mostly by John Zhang in Loma Linda University in California, and they found that it reduces hydrocephalus. So minocycline, which is tetracycline, has also gone for clinical trial in adults. But these studies were not underpowered. I would say that minocycline has promise, has potential to improve the outcome of premature infants. When you go on internet, you see garlic, turmeric, herbs improves inflammation. So I'm not sure we can ever think of giving it to the babies. You see, this is a picture from internet. Okay, now this work was done by Preeti Dohre. Preeti Dohre was a PhD in neuroscience from Lucknow National Drug Institute, and she worked in my lab for 4 years as she did this work. So she was my postdoc. Empakinase receptor inhibition promotes neurological recovery in premature infants with IVH. So we talked about in the previous slide about glutamate toxicity. So we blocked one of the glutamate receptors, AMPA receptors, by giving NBQX or perampanol. Perampanol is FDA approved, and see that if reducing glutamate toxicity improves myelination. So let me tell more about this. See, glutamate receptors are 1, 2, 3, 4. So these are AMPA receptors. AMPA receptors are tetrameric and are calcium permeable. When we use this treatment, we block these calcium channels. So again, it's a similar kind of study as I told you just now on about celecoxib. Take E29 pups, do a C-section, E29 rabbits, pregnant rabbit, do C-section, take the pups, and then give them glycerol. Next morning, see their brain has hemorrhage on ultrasound, and treat them with either NBQX, perampanol, or vehicle, means control. And then after 8 days of treatment, 7 days of treatment, like we stop treatment, and on day 14, look at the brain. It's a very simple study. And this is myelin basic protein immunohistochemistry. This is the ventricle. This is corona radiata, white matter. You see beautiful myelin staining in no hemorrhage, which is reduced after hemorrhage. You see, this is corona radiata has less myelin. When we treat, there's improvement in myelination. We quantify, we do histological quantification using a software histologer, and it showed that NBQX treatment improved myelination. So this is a very robust drug. This drug has a lot of renal side effect, but this really worked well in my animals. Then Preeti, she performed Western blot, and we found that, you see, glycerol, no IVH, and here is IVH with ventricles. So in IVH, you see there's less myelin. Bands are small, and they are less dense compared to no IVH. When we give NVQX, we could improve MBP, myelin basic protein. We could increase myelin-associated glycoprotein. Then to further confirm it, we performed electron microscopy on these brains. See, so these are, you have not to be electron microscopists to understand it. These are axons, you see? And axon is surrounded by black myelin. You see all the black gray area around the axon? This is myelin. So myelinated axons, they are reduced in hemorrhage. You see, there are fewer axons, and they were again restored by NBQX treatment. Then to understand the mechanism, we did, does it reduce inflammation? And we found that it does reduce microglia count, which is IBA1 count. It reduced TNF alpha. If you compare these two bars, you see that in IVH, there's increase in TNF alpha, which is less than 50% reduced after treatment with NBQX. It reduced IL-1 beta, interleukin 6, LIF, leukemia inhibiting factor. So this paper was published in 2016 in Journal of Neuroscience, and Preeti was the first author, and showing that NBQX perampanol treatment restores myelination and promotes neurological recovery. I'm not showing you all the behavioral data here. And NBQX treatment suppressed inflammation. Now, because perampanol is FDA approved, this might be tested for clinical trial. But NBQX was very, very robust, and perampanol was less strong treatment compared to NBQX. Okay, so we discussed about inflammation, glutamate toxicity. Now I'll talk about oligodendrocyte maturation. As I said in the previous slide, that intraventricular hemorrhage stops maturation of oligodendrocytes, the cell which forms myelin, and thyroxine promotes myelination. So I used thyroxine to treat my animals. So this was a very interesting study, and I'm trying hard to get into clinical trial, this medicine, but it's not easy to get anything in clinical trial in US. It's extremely hard. So this work was done by Linnea Vos. So Linnea Vos, she's from Seattle, from West Coast. She was a postdoc in my lab for a few years. Now, many of you may be thinking, why this investigator, why this doctor is giving thyroxine to the rabbits with hemorrhage? Does rabbit produce are they hypothyroid? Doesn't make sense to me. So let me answer this question. If you look on humans, Serum T4 is reduced in IVH. Look in the pediatrics paper, 1998, Paul et al. It shows that serum T4 is reduced in IVH. Look at clinical trial published in New England Journal of Medicine. It has shown that less than 27-week gestational age, all babies, irrespective of IVH or no IVH, if you give them thyroxine, their mental developmental index, MDI on Bailey evaluation, is improved by 18 points in multiple animal models of brain injury, both in adults, multiple sclerosis and all that. Thyroxine has shown promise. Thyroxine is FDA approved. Our endocrinologists, they come and they write thyroxine to our babies all the time, whenever they're diagnosed as hypothyroid. But it is, the story is not, like, let me tell you, let me take all of you to physiology lecture class. This is the cell membrane, you see? And this is the nucleus. Thyroxine penetrates the membrane and goes into the cytoplasm and is activated by deiodinase 2 to form T3. Hey, T3 is important, not T4, because T3 goes in the nucleus, activates thyroxine receptors and causes transcription of genes. Whereas thyroxine is inactivated by deiodinase 3. So deiodinase 3 is an inactivating enzyme which forms reverse T3 and T2. So what happens in IVH? So let us look at hypoxia ischemia data. In hypoxia ischemia, or in other models, it has been shown that deiodinase 3 is increased. So T4 is more inactivated and deiodinase 2 is downregulated. So based on this, we hypothesized that IVH would increase deiodinase 3 and will reduce the activating enzyme deiodinase 2, thereby downregulate thyroid hormone signaling. Hey, I'm having high serum T4 level, but the serum T versus thyroxine, T3, I don't have enough inside the renal cell. What good it is? So what I'm trying to say, that as soon as thyroxine penetrates the brain cells, they are inactivated by increase in deiodinase 3. And then next hypothesis, thyroid hormone TH treatment might improve myelination and induce neurological recovery in IVH. So let me show you interesting data. These are not rabbits, these are human data. Human data, so hard to get. So I collect autopsy sample, as Dr. Manoj said. So this is, I harvested tissues from the cortex, WM white matter and germinal matrix. Cortex white matter germinal matrix. So we have 1, 2, 3, 4 IVH brains and 4 no IVH brains and 4 IVH brains. And each brain has 3 tissues from 3 brain regions. You see that deiodinase 2 is high in germinal matrix, less in cortex and white matter. But when you compare IVH and no IVH, see, it is reduced. The bands are smaller. So deiodinase 2, which is an activating enzyme, is reduced in IVH in human tissues, in humans. How about deiodinase 3, the one which inactivates? They are increased. See, all over, deiodinase 3 is increased in hemorrhage. So if I have more of deiodinase 3 and less of deiodinase 2, I don't have T3 in my brain cells. So thyroid hormone signaling is down-regulated. It goes down. Similar data I found in rabbits, which I'm not showing you. So just like previous studies, I took E29 rabbits with brain hemorrhage, randomized them, give them thyroxine or give them vehicle. I use a high dose, 20 milligram per kg. My God, we never give 20 to humans. But rabbits have high metabolism, and I wanted to see the effect. So we gave 20 microgram per kg. In humans, people, they use 5 to 10 microgram per kg for 10 days. So get the premature pups, induce hemorrhage on day 1, and give them thyroxine for 10 days, every day, 20 microgram per kg by intramuscular injection. We injected intramuscular. We don't believe how much orally it goes, so give it intramuscular injection. Kill the animals on day 14 and look at the myelination. And here is the data. Myelin basic protein staining, no hemorrhage and hemorrhage. You see in hemorrhage, there is less myelination. And when we give thyroxine, again, myelination is restored. We quantified histologically and drew this graph. Myelin load, no hemorrhage, IVH with vehicle and IVH with thyroxine. You see that significant increase in myelin by giving thyroxine. And then Western blot, you see no hemorrhage. You see 1, 2, 3, 4, 5 animals. One lane is one animal. 5 animals, so much myelin. And 5 animals with hemorrhage, less myelin. You give thyroxine, it is increased. Then look at myelin-associated glycoprotein. Another component of myelin is reduced in IVH, and on treatment, it is restored. It comes back. Most people say, hey, you have to do electron microscopy and see. So these are all exons surrounded by black or gray myelin. You see myelin surrounding the exon? So myelinated exons are reduced in IVH and restored by giving thyroxine. So just to cut it short here, thyroxine improves myelination. Have you seen this in internet? What is your thyroid score? See, I'm so active. My thyroid score is high. This guy is depressed. His thyroid score is low. What is your thyroid score? So I found this interesting on the internet and wanted to share with you. Okay, so we discussed all this. To summarize, we talked about like Andrew's drift clinical trial, iron chelation, inflammation, glutamate toxicity, oligodendrocyte by thyroxine. So my clinical trial grant did very well first time, but second time it did poorly in NIH. So because it was very ambitious clinical trial. So still I'm working on it. It didn't work so far. Okay, now we'll talk about hydrocephalus. So American Neurological Association says that do head ultrasound at the end of first week, every baby who is less than 32 weeks, to screen who has IVH, who does not. My NICU, they're more aggressive. They do head ultrasound day 3, they do it day 7, they do it like at 1 month of age and at discharge. So to screen intraventricular hemorrhage. Now, babies who get intraventricular hemorrhage, we quantify hydrocephalus. And radiologists, they measure entry horn width. They were not doing it until recently they started doing it. You see entry horn width. Then helmo-occipital distance and ventricular index. So I was talking a lot about VI, ventricular index, which is a distance between midline to the lateral border of ventricle. If you have higher ventricular index, it means you have severe hydrocephalus. And this is the parameter used for most of the clinical trials. What is the ventricular index? What percentile is it? If it is more than 90% percentile, my God, this is alarming. So before we go there, let me tell you briefly about what is the mechanism behind post-hemorrhagic hydrocephalus. Why babies get hydrocephalus after IVH? So hemorrhage, there's blood in the ventricle. Blood goes in the third ventricle, fourth ventricle, and leaks out from foramen of Luschka and Magendie into cisterna magna. And they release hemoglobin, thrombin complement, causing oxidative stress. In addition, blood clot obstructs aqueduct. Aqueduct connects third and fourth ventricle. It's a very narrow space, it gets blocked. Then fourth ventricle outlet, foramen of Luschka and Magendie gets blocked. And lymphatics perhaps get blocked. We don't have data, but I'm sure that lymphatics, they get blocked. But lymphatics, when do they develop in in babies? There's not much data. So this is purely my speculation that if there is lymphatics, they are dropped. Brain does not have lymphatics, but meninges have lymphatic. This discovery was made in 2015 and 16. That brain does not have lymphatic, but meninges have, dural meninges have lymphatics. Then arachnoid villi, they do not even develop in 34-weeker. They do not develop until 34, 36 weeks. So they might be affected later on. So this will cause obstructive hydrocephalus. Choroid plexus is inflamed. This I have seen in rabbits, not in humans. That you see tons of inflammatory cell in choroid plexus, more CSF production causing communicating hydrocephalus. Now, years ago, we were using estazolamide and furosemide, but this treatment has no efficacy, zero efficacy to this treatment. They're not anymore used to reduce hydrocephalus. Repeated lumbar punctures. So there was a Cochrane review by Andrew Whitelaw, and he included 4 or 5 studies, which shows that repeated lumbar punctures does not reduce post-hemorrhagic hydrocephalus. Until recently, ELVIS clinical trial done in Europe and US showed that if you intervene in a specific window, when ventricular index more than 97th percentile, but it is less than 97th percentile plus 4 millimeter, this reduces VP shunt in 25% cases. So this was, we'll talk more about this clinical trial. And the neurosurgical treatment, placement of reservoirs. When babies are less than 2 kilo, neurosurgeons for progressive hydrocephalus, they place Ommaya reservoir. And when they become more than 2 kilo and still it is progressive, they do VP shunt. Subgaleal shunt, choroid plexus cauterization and third ventriculostomy is being tried, but has high recurrence rate. None of these treatments are really efficacious. You know, like I remember when I was a PQ fellow, I was doing cardiac massage on one of the 16-year-old who had 14 VP shunt revisions after post-hemorrhagic hydrocephalus and died of sepsis. So you can imagine that sometime there are several revisions are required for VP shunt. So let me talk about, this is Linda de Bryce. Linda is a child neurologist in Netherlands. And she asked the question that, when should we intervene in premature babies with hydrocephalus, early or late, when hydrocephalus is mild to moderate or severe? So to answer this question, she designed a clinical trial and included infants into 2 groups, low threshold, high threshold. Low threshold means that ventricular index more than 97th percentile, entry horn width more than 6 but less than 10, and high threshold means that weight, when a ventricular index becomes 97th percentile plus 4 millimeter, or entry horn width exceeds 10 millimeter. And she will do lumbar puncture, 10 ml per kg twice a day, which is very, very hard. Like when I talk to my neonatologist colleagues, my God, 24 weeker, are you crazy? You will remove this much fluid? When I talk to Linda, she says, hey, we have nurse practitioners who do it, who are trained to do it. So this is not easy. They do it in St. Louis Children's, because St. Louis Children's was one of the center for ELVIS clinical trial. And Dave, he's the he's the pediatric neurosurgeon there who is very interested in this research. So, you know, like, what was the result of this clinical trial? There's no difference in VP shunt placement or death between low and high threshold group. No difference in motor and cognitive scores at 2 years age. But in post hoc analysis, they found that when they combined death and cerebral palsy with motor score less than 70 was better in low threshold group compared to high threshold group. But there was some benefit if you go early. So based on this, Linda and several neurologists, well-known neurologists of United States, including Joe Volpe, Derinder, they wrote a review article in Journal of Pediatrics, which you might have seen, or you should look at this paper. First author is Mohammed Eldib, who is the NICU director there in Brigham Children's Hospital. And they came with this algorithm that post-hemorrhagic ventricular dilatation, if ventricular index is more than 97th percentile or entry horn width 6 to 10, then you do spinal tap. You do bi-weekly head ultrasound, and surgical stabilization means go for VP shunt or go for Ommaya reservoir placement if head size is not stabilized. But if you are dealing with severe, like ventricular index more than 97th percentile plus 4 millimeter, entry horn width on ultrasound is more than 10, or head size is growing rapidly, more than 2 centimeters per week, just go for VP shunt. While you have booked operation room and the surgery is delayed, keep on doing spinal tap. So this was a recommendation made, but these are recommendation. These are not, these are not like written in stones that we have to follow them, but this is a good guideline given by L.D. Petal, published in Journal of Pediatrics. So to summarize, we talked about removal of blood clot by drift and neuroendoscopic lavage. We can antagonize blood product by iron chelator thrombin antagonist, clearing blood clots by TPA and urokinase. I didn't talk about urokinase. And restoring CSF flow. We can generate new capillaries, new lymphatics, which I'm trying to do in my lab. Can we generate some plumbing in the brain so that we can get rid of CSF? Easy said than done. And then minimizing brain injury by anti-inflammatory treatment, antioxidant or stem cell. So arachnoid villi and VEGF treatment, all these things are experimental. Let's go about stem cell. So mesenchymal stem cell are being tried. And these are the most commonly used in clinical trials. They have good safety profile, easy to isolate, and there are pleiotropic properties in elevating organ damage. In animal study, there are two labs they are working. One is Monsoon Park Lab in Seoul. So Monsoon Park is a professor of neonatology. I met him recently. I invited him to give a talk in a past meeting. So he has done both animal studies and human studies. And Dr. Edmund Lagama is my previous division chief at New York Medical College. So when I moved New York Medical College, he's working on the same model. Some technicians, they left there and he started working on the model and he started injecting stem cell. So this is a Korean study, shows that rat model, so Dr. Park, he created a rat model of IVH by injecting blood into the rat brain. And he found that stem cell reduces apoptosis, reduces inflammation and hydrocephalus. It promotes myelination and neurological recovery. So mesenchymal stem cell has efficacy in neonatal animal models of, also in neonatal models of hypoxia-ischemia. So in phase 1 clinical trial, this is the only place where in the world they are injecting stem cell into the baby brain, into the human baby brain in Seoul University. So 9 IVH infants of 26 weeks with grade 4 IVH, he has done already, he has injected in phase 1 clinical trial and found it to be safe. You know what I mean? Like phase 1 means they are checking the safety. Now they are doing phase 2 clinical trial. Phase 2 clinical trial is ongoing. So now let us come to when we are in NICU, what do we see? Heterogeneity in the patient population. My God, some babies are 22 weekers, 23 weekers, 28 weekers. Some has grade 1 IVH, grade 4 IVH. The baby has complication of RDS, PDA, necrotizing enterocolitis, low platelet. Platelets are low. How can I do neuroendoscopic lavage? Premature babies are very small and fragile. So we have a lot of limitations. It's not easy. So these are some of my speculation that grade 1 and early grade 2, no novel therapy should be done. Just leave the baby alone. So these are purely my speculation, which I published, which, like in my review article, I discussed it in Outlook section. This is like paper you might have seen published in Nature Neurology Review, and so grade 1 and 2, at this time, no treatment. If it is grade 2 and grades 3, perhaps stem cell, thyroxine treatment, or neuroendoscopic lavage might be tried. So these are just my speculations. Once again, grade 3, 4, hemorrhage, neuroendoscopic lavage, stem cell, thyroxine, anti-inflammatory treatment. So these are some of the things that we can, that is perhaps there's going forward might work. So when I was talking to my neonatal fellows, one of my neonatal fellows, she's very funny, and she sent me this cartoon, which I wanted to share with you. Dr. Ballabh, would you like to practice before starting new treatment? So she sent me this cartoon, you know what I mean? And So this is my some of my lab colleagues who are in this picture, and my collaborators at different universities. The work is funded by NIH, R01, R21 grants. Thank you very much for patient listening.
Thank you so much, Professor Ballabh. As usual, your lectures are amazing in all ways, and then it adds all the punches and then stimulates us. Now we go on to the panel discussion. I would request the moderators, Dr. Suti and Dr. Binish, to take over.
Thank you, Dr. Ballabh. It was an enlightening talk, introducing us to the New Year treatment options for post-hemorrhagic hydrocephalus and the white matter injury. So just to summarize, kind of like, we went through like the neuropathological changes which we see post IVH. Then like what are the different types of pathogenesis of white matter injury and the strategies to reverse the white matter injury, which included like the medical part of the management, iron chelation, and the surgical management, including like drift and NEL. And then you gave us an insight about the pathogenesis of post-hemorrhagic hydrocephalus, and then the management of post-hemorrhagic hydrocephalus, like the different newer options which are available, including the Elvis trial into LP versus no LP, like when to do it, and other neurosurgical management. So I think now it's time for like some of the questions, if you would be able to answer those. So the first question is from Nitin. So he's asking whether T3 and T4 levels should be done prior to and after the study, like if we are trying the thyroxine.
So thyroxine treatment in human babies should only be done after IRB approval. Should not be tried because this will be off-label and is not indicated at this time. And then when you design a study, then if you can certainly, like when I designed my study, which I submitted and it has not been approved yet, and I'm not sure, like these clinical trials, these very expensive clinical trials will ever get approved. Like certainly we should do thyroxine level before treatment. Whole thyroid function test should be done before instituting treatment, and every week and 2 weeks after completion of treatment. So this is what we proposed. But as I said, these are all experimental and depends how you design the study, taking into the consideration the safety of babies.
Thank you. So next is Maria, who's asking, what do you think about ventricular taps? The role of ventricular taps.
So ventricular taps are being done, but when you need too many ventricular taps, each time you poke the brain with a needle, we are going to cause damage, is that right? So that is why the surgeons, they do Ommaya reservoir. Ommaya reservoir are being used for less than 2 kilo babies. Because if you do VP shunt early, it is more likely the chances of failure is much higher because of the, fibrin and different CSF content, which can clog the reservoir, which can cause the VP shunt. So in general, routinely ventricular tap is not being done here. Like if we need, they may do spinal tap, and when we need multiple ventricular taps, we do Ommaya reservoir, and then we tap the reservoir. So tap the reservoir in place of each time poking the brain with a needle.
Thank you. Next question is very relevant and which every neonatologist kind of faces in daily practice. So this Bharat says, Dr. Linda was lucky to work with neurosurgeons who agreed to intervene at 97 centile and not wait until 97 plus 4 millimeter. So we always find resistance from the surgeons. Like, how do you suggest, like, we could get the surgeons to agree, like the neurosurgeons to agree to intervene early?
Welcome to the club. So this is the problem. My neurosurgeons, they are the same. You know what I mean? So it depends, like talking to them, discussing to them, like showing them the data, that is the only way. But similar kind of resistance is being felt, not in India or anywhere, it is perhaps all over the world. Because with all respect to my neurosurgeon colleagues, the only way is that we have to convince them by showing the data and discussing them in inviting them in the in NICU with fellows, residents, and everyone, and discussing that this is the need and this is what the data says. Why we cannot do this? But this is the same problem which I have in my NICU. So I don't have a solution.
To Dinesh.
Again, just to repeat, thank you, sir, for the enlightening talk. And really got impressed with the results of the thyroid, because not every day that you see some intervention that cause a major difference in the IQ points by around 80 points, 18 points. So that's something very impressive. So just to continue the questions, Dr. Richie has asked, before the intervention, do we really need all the three measurements of the hydrocephalus, like ventricular index, anterior horn gate, and the thalamo-occipital difference? Or just should we go with any one of them? Like mostly we go with the ventricular index only. So what is your opinion, sir?
Mostly people, they use, if you look at clinical trials, they use ventricular index. And some of them, they also use AHL, entry horn, AHW, entry horn width. You know what I mean? These tools should be enough. You know what I mean? And my radiologists were not doing it, but now we ask them, and then they do it because it's an extra work for them. So if you want to follow how hydrocephalus is improving or how it is progressing, this is the way to go: ventricular index and entry horn width. So ventricular index is being used mostly in all clinical trials. That is the most important thing.
I guess the next question was already answered. And the other question is, so do you have any specific bundle of interventions that to suggest to help to prevent the IVH in preterms? Many hospitals have this IVH.
I got your question. Prevent IVH. If I don't have IVH, then there's no problem. So in the beginning, in the early stage of career, when I was just a new attending, I thought prevent preterm labor. If there's no preterm labor, then there's no problem. Then I thought, my God, what will happen to all my neonatology colleagues? What they will do? They will lose their job, isn't it? So just coming to your question, that how to prevent IVH. The only way to prevent IVH, or you can say the best way to prevent IVH, is prenatal corticosteroid. Prenatal corticosteroid. So how does prenatal corticosteroid work? I did not know until 2010. I published a paper in Stroke in which we used human tissues and rabbit study, and it showed that prenatal corticosteroid reduces angiogenesis. It downregulates vascular endothelial growth factor. So the answer boils down to the question, why babies get IVH. So I teach my neonatal residents, and it is, as in several of my review articles, they show that premature babies bleed because blood vessels are fragile and rapid fluctuation in the blood flow. When baby is in utero, there's no fluctuation in the blood flow, or relatively minimal fluctuation. When babies are born, doctors, they put endotracheal tube, they do IV, they poke the baby screams, and there's a fluctuation in the blood flow in the brain, which breaks down the fragile germinal matrix vasculature. And one of the best work which we did was that germinal matrix has rapid angiogenesis that we discovered in 2007, which came as a cover page article of Nature Medicine, that there's nowhere angiogenesis in the brain except germinal matrix. And when nascent vessels are produced, they are naked endothelial tubes. Their basal lamina is very, very weak. They don't have fibronectin. Pericytes are not yet recruited because when these vessels mature, pericytes come and they surround and recruit the vessel, make them smarter, make them stronger. So germinal matrix fragile vessels, they can be pruned, they can be removed as you decrease VEGF. VEGF means vascular endothelial growth factor. So when you reduce vascular endothelial growth factor by giving corticosteroid, then it kills all the naked endothelial vessels. It suppresses angiogenesis. Same thing we did, that we used anti-cancer drug, ZD647 in my Nature Medicine paper, and we removed all the premature blood vessels by using anti-cancer treatment, and we give glycerol to the rabbits. They did not bleed. Give glycerol, they do not bleed. So angiogenesis suppression reduces general matrix hemorrhage. And so corticosteroid does it, so there's no point of using something else. So corticosteroid reduces the general matrix and improving the clinical care. Minimal handling, isn't it? Proper fluid balance, keeping platelets at least more than 20K. That reduces IVH. But despite all this, the incidence of IVH has a kind of plateaued over the last few years. Still, it is a problem. So this was a kind of way too comprehensive answer to your question, to like $1 million question, can we prevent IVH?
Thank you, sir. Then the next question is from Eugene. Yes, do you think there is room for neuroendoscopic insertion of stents to keep the outlet foramina patent to prevent blockage by blood clot?
So see, depends how frequently we get obstructive hydrocephalus and how frequent hydrocephalus is communicating, isn't it? If it is a obstructive hydrocephalus, where is the obstruction? Is it in aqueduct? Is it in foramen of Luschka and Magendie? So I was talking to Dave. He's the chief neurosurgeon at St. Louis Children's, interested in hydrocephalus. I said, my God, obstructive hydrocephalus are so hard. Then he says, Praveen, we do third ventriculostomy. We make a stoma in the third ventricle so that you can bypass aqueduct, isn't it? You can bypass, like foramen of Luschka and Magendie. Then I said, how successful is it? How frequently you succeed in doing it? So, so these things are, so third ventriculostomy is a good option. Theoretically putting a stent wherever, if it is aqueduct, put a stent. If there is in foramen of Luschka and Magendie, you can open it. So these are theoretical possibilities. But this is an excellent question.
Okay. Next question from Liver. So the question is, what do you think about the administration of intranasal colostrum in intraventricular hemorrhage?
Which one? I'm sorry, I missed that. Which treatment?
Intranasal colostrum.
Oh, yes.
In IVF.
So, yes, there was a clinical trial in which, intranasal colostrum was given, and it was a small clinical size, as much I remember, a small sample size. If sample size is small, then you do not know how the result is. But anything you give intranasal goes in the brain, isn't it? A lot of studies. If you put something in the nose, it passes the cribriform plate and goes in the brain. So milk has a lot of growth factors, and these growth factors are neuroprotective. So it is possible that intranasal colostrum might improve in general outcome of these babies. Might improve the, neurological outcome. Now, whether it will reduce hydrocephalus or not, I do not know, because unless we have something that can reverse hydrocephalus, it may not work. But certainly intranasal colostrum has promise, and people are still trying on it. Again, excellent question.
Yeah. So next we have from Fahri. So the question is, we gave stem cells in an infant with periventricular hemorrhagic infarction and hydrocephalus, but also had to put in a reservoir. So when would it be appropriate to drain CSF in such an infant? Like, when does the effect of stem cells begin in IVH and periventricular, ventricular dilatation, post-hemorrhagic dilatation?
So, I was talking to Andrew Whitelaw in one of the conferences, the PI for, because he all the times comes for past meeting, and we talked, then we were chatting that you put so much effort doing drift clinical trial, and then we did not get the expected result. Then I said, Andrew, I do not know, but my guess is you went too late. Day 21, there's hemorrhage, and in 3 weeks there is so much scarring in the brain. So what good it will do if you go so late? He said, hey, my clinical trial was start for secondary hemorrhage. If I go early, you cannot do anything. There will be more hemorrhage, isn't it? So, but the stem cell injection, sooner you give, better will be the outcome. Why? Because stem cell, these are mesenchymal stem cell, they do not cause cell replacement, but they reduce inflammation. That is the mechanism. So sooner you give, better it is. So stem cell, if it is given, but you can say, my God, baby has grade 4 IVH, and you want me to put needle on day 1, day 2, day 3, it will make IVH worse. So we have to weigh what is when you are comfortable, one family is comfortable, and what is the best time. Perhaps because IVH is first 3 days thing. After 3 days, babies, they do not get IVH. They become immune. Unless there is drop in platelet, unless there is a bad pneumothorax, IVH is first 3 day thing. So I think that at the end of first week, day 5, day 7, if like we can inject a stem cell, but how do you want to inject a stem cell? Directly in the brain, or you want to give IV? But most people, they want to inject directly into the brain. So if you want to go directly in the brain, I would propose that at the end of first week, we can inject. And if there is hydrocephalus, then we have to treat, you know what I mean? Following the same recommendation, which has been proposed by Journal of Pediatrics Investigate, and based on the paper published in Journal of Pediatrics, or whatever your neurosurgeon believes.
Thank you. Eugene asks, is exposure to oxygen in extreme preterm a risk factor in developing IVH because of free radical damage?
See, what contributes to there's no clinical trial to prove it, but anything which causes fluctuation in the blood flow will contribute to IVH, isn't it? If hypoxia, hyperoxia, hypercarbia, everything causes fluctuation in the blood flow. If there's any fluctuation in the blood flow, it might contribute to IVH. So I will say very guarded statement. It's a great question, but I do not know the exact answer. I would say that hypoxia, hyperoxia, more oxygen, free radical injury, it will affect the blood flow in the brain, and it might contribute to IVH.
So the next question is from Dr. Jalil. It's about the role of early therapy with ethamsulate as a prophylactic agent in at-risk preterm babies.
So these are not proven. These are all empirical, and there's no data on it.
So the next question is about the monitoring using the ventricular index. Most of the charts had ventilator index till 41 weeks of post-menstrual age. So what cutoff do you take after this 41 weeks of post-menstrual age?
41 weeks of age, yeah, this is a good question. If you don't have nomogram, then you go by common sense, isn't it? If you do not know what is the 95th percentile, but most of the time, I never come across this situation. We start intervening early on, and I think that we have to go by common sense and guesswork. And then if you don't have nomogram, then what we can do? So I do not know that what is the cutoff if I don't have a nomogram.
So the next question is regarding the ultrasound measurement again, about the anti-horn cell width exactly. Is there a particular section or view? Which section or view do you prefer to measure the anti-horn width?
I do not know, because most of these measurements are done by radiologists. Simply we our fellow calls reports entry horn width, then how do they measure? I have never done it, so I'm sorry, I do not know the answer to this question.
Okay, so the next question is, what is the best time to initiate any treatment once we diagnose higher grade like severe IVH? Like, can we do anything to reduce brain damage in the active phase of bleeding?
So, these questions are experimental. If you ask me what you do in NICU, a grade 4 IVH, When I sign out, my colleague will say, Praveen, did you talk to the family? Grade 4 IVH, yes, I did. So, like simply we follow, there is no treatment at this time. And everything is experimental, means that this is all preclinical studies. In humans, there is no study. Only we tell the family that, I'm sorry, your baby has a grade 4 IVH. This is the risk of brain injury. And, and we follow the head ultrasound to see that if there's a hydrocephalus, when we can intervene. So there's no treatment that we do on like in any even severe IVH. And this is true not in my NICU, it is all over United States and in all over the world, that there's no treatment. I wish, like a treatment would have been easy and simple to do it. So these are like very good questions, which I'm sorry, I don't have answer.
Next question by Anita, like regarding the anti-VEGF, what we were talking and the role of steroids. So she's asking, like anti-VEGF activity, doesn't it cause any problems because of its activity on, aborting the angiogenesis, like suppressing the angiogenesis in other places?
Right. So when I started my career and we published this Nature Medicine paper, 2007. So, like I was very excited. I thought that anti-VEGF treatment is very good. I wrote NIH grant suggesting that we should do anti-VEGF treatment. And NIH scientists, those who go to review, they said that, my God, this guy is going to stop angiogenesis in the whole brain. So this is not a good treatment. I could not sell them. But on other side, brain does not, like 24-weeker brain, or anywhere beyond 23-weeker brain, there's no angiogenesis in the brain, except ganglionic eminence. I mean no angiogenesis means it is very minimal. If you see proliferating cells, you see only in the ganglionic eminence. By ganglionic eminence, I mean germinal matrix. Like basic scientists, they call it medial and lateral ganglionic eminence. And my NICU says germinal matrix. So that is the difference, sitting on the head of caudate nucleus. So anti-VEGF treatment, any treatment. Now, when we give corticosteroid, what it does, it decreases VEGF. Is that like, it decreases VEGF. So indirectly, because there are a lot of clinical trials on prenatal corticosteroid, and all these babies, they do well. So no one cares. No one thinks even about angiogenesis. Anyway, every treatment has adverse effect. Is there a treatment in the world which does not have adverse effect? So we have to weigh risk and benefit, risk and benefit. So corticosteroid treatment is a proven treatment to prevent IVH, and it does have adverse effect, but those are minimal compared to benefit we get, because we know that prenatal corticosteroid reduces RDS, reduces IVH, and improves the long-term outcome of babies. If you ask me, like in neonatology, what is one of the best research? It is perhaps prenatal corticosteroid, isn't it? Which has improved the outcome. We feel very happy. 23-weeker, first question we ask, mom got corticosteroid? Yes, got. Oh, good. So that is how we respond, that this baby will do good. No corticosteroid. So smaller hospitals, they think that, my God, we should refer this baby to higher center. This baby will not do good. This is 23-weeker, no corticosteroid, baby is going on higher, setting in ventilator. Why don't want to give these babies? Transfer it to higher center, to grade 4, to level 4. So corticosteroid is perhaps one of the best, prenatal corticosteroid is perhaps one of the best things that we have done, that has helped babies, to my mind, and what most neonatologists believe.
Next question by Raj. So is there any role of prenatal magnesium sulfate in the prevention of IVH?
See, prenatal magnesium sulfate, what it does, magnesium goes and sits in NMDA receptor. It blocks it so that calcium cannot get in. If more calcium goes inside the cell, it activates all the enzymes, nuclease, DNAs, RNAs, and causes cell lysis. So magnesium sulfate treatment is a proven treatment for improving the neonatal outcome of babies. So this is abundantly being used. Of course, when we give neonatal corticosteroid, it's hard to feed the babies, isn't it? They get distension, there's the ileus, they become apneic, we have to put them on CPAP, sometimes intubate them, but despite that, magnesium sulfate improves the neurological outcome. But Does it reduce IVH? There's no study showing that it will reduce IVH. And if you think mechanistically, why magnesium sulfate will reduce IVH? Does it change the fluctuation of the blood flow? Does it strengthen the blood vessels? Perhaps it does not. So as much as I know the literature, magnesium sulfate improves the neurological outcome, but may not reduce incidence of IVH.
So the next question is probably out of topic, so I will just modify it. So we faces a lot more of post-infectious or post-meningitic hydrocephalus than post-IVH hydrocephalus probably. So do you think any of these strategies may work in post-inflammatory or post-meningitic hydrocephalus also?
So to tell you the truth, like in NICU, like rarely we see post-meningitic hydrocephalus, rarely, you know what I mean? But like if there is hydrocephalus and if we do not do like Omaya reservoir or if we do not do, like a VP shunt, hydrocephalus will keep on getting worse and worse, isn't it? And more is the hydrocephalus, more is the brain injury, isn't it? Because we think that, like a lot of even my colleagues, they believe, hey, we do VP shunt, brain is fine then. No, it doesn't happen that way. Like if brain ventricle becomes bigger and bigger, the axons, they are being stressed, they are being torn, they are damaged, and you cannot fix them. Once axon is gone, it is not going to regenerate. So timely treatment of any hydrocephalus is important. In place of delayed treatment, a high threshold group, scientifically or logically, if you think, is like we must do timely intervention for any hydrocephalus babies. This is my, like my thought.
So the next question is there a need to do serum calcium levels, especially in patients where we may consider AMPA blockers for IVH or seizure?
I'm sorry, for what? Like a calcium level for what?
Before we consider AMPA blockers.
What is AMPA blockers?
So the AMPA receptor blockers, I guess.
Okay. Oh, AMPA receptor blocker. Okay, yeah. I'm sorry. So AMPA receptors, you know what I mean? These are just in the lab, because AMPA receptors, like NBQX, you cannot use in humans. It is known to cause kidney toxicity. Perampanol had some effect, like it has never been used in babies to reduce brain injury after IVH. It is again, if someone wants to use perampanol in babies, you know what I mean, then we need a IRB approved protocol, because this is an off-label use. It is not meant to reduce the brain injury. So, like when we use this, serum calcium level will be, like it may be good to do calcium level, but it blocks the receptor. It does not affect the serum calcium level. It may be good to check that what is the calcium level, but logically, they block the receptors. They do not reduce calcium level.
The next question is regarding, sir, is there any preferential anti-epileptic drug for the treatment of IVH-related seizures, probably regarding the reducing the risk of apoptosis?
Like I don't think that people use the same anticonvulsant treatment. My child neurologist, whenever we have seizure, they still load with phenobarb. They use the same drugs. They are not using anything different for babies.
So next question from Eugene, who's asking like your comments on neuroplasticity and IVH.
So neuroplasticity is, my God, is a big question. It is a very important question, that is brain plastic? When you can reverse injury, you know what I mean? So this brings in question that when does neurogenesis stop in the brain? Production of neurons, isn't it? When does the gliogenesis, oligodendrocyte formation, stops? So this question was not being answered in humans. So we did a study in 2013 on my like human autopsy samples, and we published perhaps in 2013. Sabrina Malik, she was my neonatal, she's the first author on the paper. that neurons are produced, I mean, glutamatergic neuron, pyramidal neurons, 90%, 80% are glutamatergic neurons. They use glutamate as a neurotransmitter. They are produced until 28 weeks of gestation. After that, we did not see in autopsy samples any proliferating, any neurogenesis. But interneurons, which are inhibitory, they are produced until 40 weeks. This we published in Cerebral Cortex around the same time, that interneurons, they are inhibitory neurons. They are produced until 40 weeks. So, and then, like it is not simply neurons, it is synapse formation, isn't it? Because final thing is synapse, because circuits are formed by synapse. So synaptogenesis continues even later on, dendrite formation. And there is some vague data, but when the synapse, like when a neuron is damaged, it will try to form alternate circuit with another neuron. So so these questions are very difficult to answer, but we can say that plasticity of the brain is limited at, like after once babies are born, it is limited. There could be some plasticity. Like when we do physical therapy, when we send our babies to early intervention, to babies with, like IVH, and all these therapies, they improve plasticity of the brain by creating alternate circuits, isn't it? More synapse formation, so that outcome improves. So, like a brain is certainly plastic. Otherwise, how this, like physical therapy will work? You know what I mean? Occupational therapy, physical therapy, speech therapy, which is the best treatment available for babies with disabilities. So brain has plasticity, but is limited. And this we exploit by using these therapies.
And from Eugene again, asking about the role of therapeutic hypothermia treatment and IVH. Like we know that like hypothermia is not recommended in preterm, but is there any advantage of therapeutic hypothermia? And
everything is cost and benefit, isn't like how much is the risk and benefit, that is the main thing. And hypothermia has not been recommended for premature babies. And then what hypothermia does, it does improve the outcome by 10-15%. It does not totally fix the brain. So, like in premature babies, 23 weeker, like they are so fragile, 25, 26 weeker. If you let them go through hypothermia, I think that our survival will be questionable, because we are not even talking about 34 weeks. Most of the IVH babies are 23 to 28 weeks in my NICU, 30 weeks, isn't it? So small babies doing hypothermia will be, it will be a major undertaking. And, like this has not been tried, but even, like less than 36 weeks, we do not do hypothermia. You know what I mean? So hypothermia treatment is, like these things are like not proven and are very risky. Even doing clinical trials will be, like it will be very hard to get IRB approval on these babies.
the next question is kind of already answered. This question is from Shyam Sidana from Ranchi. I think the question is again about ethamsulate, which you already kind of addressed previously.
Right, yeah.
Next question is there any role of like cold therapy over the scalp to prevent or treat IVH in neonates?
No, I don't think there's anything, like in my NICU, there's a nursing protocol, you know what I mean? Which I always tell them that why you guys do it. Keep the head in the center. Do not move it right, left. Keep it like this. It will reduce IVH. So these are all empirical, you know what I mean? Putting something cold on the head, you know what I mean? Well, like I'm not sure, like how much it will help. But these are unproven therapies and based on myth. And I don't see any scientific basis of doing this at this point.
The next question is regarding any role of early indomethacin, IV indomethacin to reduce IVH.
So, like indomethacin was Dr. Laura Ment. She's a well-known child neurologist at Yale, you know what I mean? So she is the one who does, like when you go to Yale University NICU, babies are born, start them on indomethacin. You know what I mean? Every baby used to go, this is not, I'm talking about earlier, going on indomethacin. So indomethacin, is basically what? Is a non-selective COX inhibitor. It blocks cyclooxygenase 1 and 2 receptors. So when you block these receptors, it will reduce angiogenesis, isn't it? Because blocking COX receptors also reduces angiogenesis. In my model, when I give celecoxib, IVH was less. So it does help, but these clinical trials have very small benefit. Even when you look at, because eventually, how does my baby look when baby is 2 years old? How does baby fare in Bailey evaluation? What is the mental developmental index? So these are not improved by doing indomethacin, except in a small fragment of male babies, she found some benefit. So indomethacin is not a proven treatment to reduce IVH in premature babies, and is not being practiced in USA. But good question. These are like very good questions.
We finished the questions in the Q&A box, and one question I can see from the YouTube link is regarding the criteria to remove VP shunt on follow. If you have
like this, like these are questions which can be answered by neurosurgeons, because when we have a baby, if surgery comes and does place the line, we don't even touch it. Let surgeons come and remove it. But doesn't mean that is a great question. But I'm ill-informed. I do not know that what is the best time when they remove VP shunt. Is that the question?
Yeah, yes, sir.
Yeah. So VP shunt, I have not seen, because I do not follow these babies, although being neonatologist for 25 years, I've never seen babies, they go home, and then once baby is 2 kilo, 3 kilo, and I do not follow up them. So I do not know answer to the question that if they have removed, I can guess that, when progression in hydrocephalus slows down, or because once VP shunt is placed, they are being replaced whenever there's infection, there's a block. So I do not know the answer to this question. It's a great question, but I'm sorry, I do not know the answer. A neurosurgeon will be a better person to answer. But it was a beautiful, very good question.
I guess that's about the questions. We finished almost all the questions that has been mentioned. And thanks a lot, sir, for spending the time. Over to Manu, sir.
It was a joy. It was indeed a pleasure, giving this talk and answering all those great questions from, all across the world and from India. I have a great time. And I
thank you so much, Professor, for sparing your time. Actually, we apologize. It took more than the time you allotted for the question answer session.
No. I have plenty of time. Time is not the question. I'm sitting in my lab. I
believe it is 11:30 already your side.
Yes, it is 11:25.
Yes.
I'm not in clinical service. When I'm in clinical service, then of course I cannot do it. But if I'm in lab, I'll see my postdocs, my one junior faculty, what kind of experiment they are doing. They're on confocal microscope. I will go and sit back with them, see some of the slides, how things are developing in the brain, all that we are working on. So I worked with them as a team. So it was a joy. It was really a joy, giving this talk. And thank you very much for inviting.
It was our honor, actually, to have you a lecture.
I did not know that. Thank you so much for saying. Yes, so kind and sweet of you.
Now, we have Dr. Surendra Singh Bisht. He is the Secretary General of National Neonatology Forum India. So
Yeah.
I would request him to propose a vote of thanks before we close.
Hi, Dr. Bisht. So good to see you. It is a
Hi,
joy.
Dr. Praveen. And Manoj, Dinesh and Shruti, thank you for conducting it so well. And I'm so happy in 2019 when I went to New York for PAS, I took one whole day. Apart that, this was the first visit to US. I've never been to US. I'd gone on ICMR grant. And I thought it will be a day well served if I can make an appointment with Dr. Praveen and visit his lab. And I'm so fortunate that the thyroxine studies which he's telling right now was being done at that time, and I could see those rabbit pup models, I could see those electron microscopic neurons which you were trying to tell me. And the goosebumps were there for many days. I was not happy with the Statue of Liberty or the other things in New York, And the goosebumps were there because of your lab, your electron microscope, and your studies which you're doing your model. And those days you were out of, you were in a clinical service, or maybe you were not, you were in a clinical service those days, and you were still doing a lot of lab work. Manoj, in fact, there were only 4 people that day, I think, remember, 3 or 4 people in your lab that day.
So
And
you
he
came
was
to my
like,
lab? Yes. So
I
yeah.
was in your lab. I was,
Yeah. So
I am so
2019. Okay, I'm sorry I missed you. I apologize. But
I came to your lab and he was doing all the job himself. Everything is being done by himself.
right.
That's such a kind of a big thing.
Yeah, but
And
like from outside, it looks very green. But like when, and I cannot tell you how much I struggle to get my
I
grants.
know. I saw those.
How many
Everything.
times?
In fact,
Like
he has to arrange
70
for a
times my
cleaner.
experiment they do not work. I fall on the face again, stand up and do it. So like so it is like very challenging to do like to do like a research and working every day. But I enjoy it still. I do not know. This is I have been
so thankful,
created to
Dr.
work.
Praveen, that you could say so many times, I do not know, I do not know, and do not, I know it, and that I know it all. Attitude was certainly not there, and all the questions which were there. And though you have the answers, you are trying to get the answers for future therapies, you are still saying, I don't know about right now, and you are kind of dissuading people for directly jumping into clinical trials and trying to wait for those things, despite doing a lot of basic scientific research into this. That was great. And thank you. And I think, Manoj, the day when he said yes, I had a morning jog from in Pune. I was running, and in the morning jog, I went to Ganpati, Dagdu Seth Halwai Ganpati in Pune. And as soon as I came out from that Ganpati temple, his call came that I'm ready to do a session, and I was so relieved that Ganpati actually listened to
like
my.
that is not a problem. Anytime you give me 24 hours, I can give a talk. It's not a problem. Because this is what I do, and it's my honor and joy to give a talk.
No,
So
it was a Ganpati
anytime
call.
you
Actually.
invite, I'm there. I didn't respond in a timely manner because I do not see WhatsApp all the time. You know what I mean? So if you email me in Einstein EDU email, I will see it immediately. WhatsApp, I check maybe once a week. Sometime I forgot. People, they complain, you don't answer. I said, no, it's not that. I missed WhatsApp. Like, but you have my phone number, you can call Einstein Med EDU. I see it 5 times a day because that is on. That is important for communicating with like with my NICU and everything. So like it is a joy, and anytime, any kind of talk. I have a lot of talks which I keep on doing. You know what I mean? And I'll happy to do anything. But thank you so much for so much of love and that you guys are like overwhelming with. I'm really very happy being a part of today's, like presenting my work. Thank you so much.
Thank you. Thank you so much, Professor. Once again, I would also like to thank both the moderators, Dr. Shruti and Dr. Binesh, for conducting this session so well. And before we close,
we have Professor Banchari also.
Yes, I spoke to him previously. Are you still there, Professor Bankalari? No, he said he will have to leave towards the end.
Right. Yeah.
Otherwise, I wanted him to give few comments. We have the Miami meet coming up, so probably next time he'll be able to tell us more about it. So now, before we close, I would also like to thank all the respected attendees from all over the globe who have been watching the serial right from the beginning. This is, we are completing 3 years now. June 2020 we started. Now it's 3 years over.
Yeah, and congratulations. You guys are doing a great job. Yeah.
Thank you, sir.
Because educating the like all pediatricians across the globe, this is very important. Without education, like how we can deliver to our patients. So you guys are
we should actually thank COVID for this knowledge transfer series. Because of the COVID only we began this and initiated this, and then it got on actually.
Right. Yeah.
So I would, before we close, I would invite you all for the next session, that is on 13th of July on metabolic bone disease of prematurity, by Professor Amchu from University Calgary, Canada. So until then, let me thank all of you, and then again invite and thanking Professor Praveen Ballabh personally for agreeing to do this talk. With all your permission, we'll close now.
Thank you. Thank you.
Manoj,
Bye-bye to
Yes,
everyone.
yes.
Manoj,
Please.
now that we have to write an email to all the earlier
We
speakers as well.
we will close the session and talk, Surendra.
Okay.
Yeah, okay.
Okay. Bye-bye, everyone.
Bye.
Bye.
Thank you.